Good afternoon, everyone. My name is Jacinta Smith, and on behalf of the PCPCC Support and Alignment Network, I want to welcome you to today's webinar on enhancing medication safety and e-tool use. There are a few housekeeping items I want to go over before we begin. We have a packed but engaging webinar planned for you today, so please be sure to share your comments and questions in the question panel throughout the presentation. We will also answer questions at the end. Today's webinar is being recorded and will be made available on our website 24 hours after the live event. The link to our website will be posted in the chat box shortly. You'll be able to access the recording and webinar slides on this site by tomorrow afternoon. I would now like to introduce our guest speakers for the afternoon. Our first speaker will be Mary Minetti, who is a Senior Policy and Program Specialist at the Institute for Patient and Family-Centered Care, which is also a partner organization of the PCPCC SAN. We will then hear from Bryant Campbell, who is a patient advisor from the Providence Medical Group in Portland, Oregon, and Randy Fenninger, who is a TCPI National Faculty member and the CEO of National Blood Clot Alliance. Thank you again for joining us, and I will turn the presentation over to Mary at this time.
Great. Thanks, Jacinta. I want to welcome you to this webinar, and I hope that you find it very helpful. Part of what we want to do during this webinar is really spend some time on the next, Jacinta, these slides aren't moving for me, the next 3 metrics that are part of the TCPI project, and we hope that it will give you a framework in which to expand your PFE efforts in your practices. Most of you, I imagine, are part of the TCPI Transforming Clinical Practice Initiative, and we're all about improving quality, reducing costs, and enhancing the patient experience. One of the things that's true about person and family engagement is that this has become a strategic framework for CMS, and they are linking PFE practices into all of their programs, and they are also creating the opportunity for linking it to payment as well. Just as a level setting, I want to just be really clear that person and family engagement is about creating an active partnership with patients and families at 4 levels, but we're going to focus on 2 levels today in this webinar. One is on direct care, and the other is on organizational design and governance. So in addition to talking about medication management and e-tool use, we're going to be talking about how to engage patients and families as partners in quality improvement. And it's a continuum. We eventually want to move to, and many of you may already be there, in partnership and shared leadership, which is on the far right of the slide, where we're really co-creating plans, individual health plans, care plans with individuals, and we're also working with patients and families to co-lead change. But we have to start somewhere, and so we often start on the left side in consultation and move toward more effective involvement. And so think about where you are on the continuum, and just know that true north is toward collaboration and shared partnership. Many individuals want to know, well, why, besides the fact that CMS has it as a strategy, would we be interested in person and family engagement? And I would just bring to your attention a recent white paper that was written by the National Academies of Medicine around harnessing the evidence and experience to change culture to patient and family-centered care. And the evidence is compelling about how it improves care, reduces costs, but it also increases the joy of practice for clinicians and staff who are working directly with patients and families. So for those of you that need more evidence to convince your colleagues or to help them understand the compelling reason why we are moving in this direction, share that evidence from that white paper, or also be aware that the CMS quality program, payment program, is MIPS and MAPS, is really something where you can make yourself more available to reimbursement by being involved and really embracing person and family engagement. So we hope that you're ready. We want to talk a little bit about the the performance metrics at this point, and then I'm going to turn it over to my colleagues who are experts as patients. So we have been working on selecting metrics that reflect the intention of creating real partnerships with patients and families. And there was a Patient and Family Engagement Advisory Council that happened over a year ago, and they helped create a framework. And then we looked at the framework that they'd created, and we prioritized 6 metrics and piloted some questions that that are being asked by all TCPI practices. And in terms of where we're currently establishing the baseline for what are the practices that organizations and clinics are using currently, with the expectation that all 6 metrics would be over time implemented as best practice in clinic and ambulatory settings. In 2017, June of this year, these questions will be integrated into the practice assessment tool. So right now the PTNs, Practice Transformation Networks, are working with practices to see where you're at, and then you'll be reporting on your own progress over time. And these are the 6 metrics. They cover governance, point of care, opportunities and policies and procedures. And we're going to be talking about support for patient and family voices, e-tool use, and medication management today in this webinar. So the first slide is around support for patient and family voices. And this is the question that you'll see on the patient practice assessment tool, PAT. Do you in your organization have policies and procedures and practices and actions that are going to support integrating the patient and family voice into the operations of your clinic? And it can take the form of a patient family advisory council, or involving patients and families from your practice on improvement teams. But the reason that we believe that this is such an important and key program element is that including the perspective and voice of patients and families can make a difference, can reduce costs, can improve quality, and can really add value based on what's important. And there are many articles out there, but if you really are, and this is the Transforming Clinical Practice Initiative, wanting to really have key levers to drive and accelerate that change, leaders in organizations who have fully implemented person and family engagement through a patient and family-centered care culture cite this one action as being that which really made a big difference in their transformational change. The second metric that we are highlighting today is one that many practices through meaningful use have already begun the process of implementing, and that is using an e-tool, either a patient portal or some other e-connectivity, to be able to have bi-directional communication with patients and families, so that care is the sharing of information between office visits as well as that which is hands-on care in the office practice. And it really is a way to create ongoing partnership and interaction and communication. And why do we care about that? Well, what we know from many studies is that 40 to 80% of medical information that patients are told in an office visit are forgotten immediately after. And so how are we going to provide the opportunity for people to share that information? Well, we found through Open Notes, which is opening up the entire record through the patient portal, including the doctor's notes, and is a very innovative and forward-thinking expansion of patient portals, its e-connectivity, that studies of the implementation of Open Notes and effective use of patient portals has really improved the clinical aspect, helped with quality and safety. And so there are lots of compelling reasons. And the third metric that we are highlighting today has to do with medication management, and not just what we're doing in the office in terms of reconciling medications, but how do we collaboratively work with patients and families and support them in their management of medications, because ultimately they're doing the medication management 24/7, 365 days of the year, and our interventions are sporadic and around those time periods. And this is a safety measure. This is really around making sure that patients and families understand the purpose of their medications, do not have an extensive treatment burden because of the volume or the number and complexity of their medications, and that we understand what's working well for them and how we can improve it. And why do we care about this? Well, the data in front of you tells part of the story. People aren't taking medications as prescribed. Sometimes they're leaving the office and not even filling the prescriptions. And so having meaningful conversations and engaging patients and families to understand the whys behind that and what we can do to support them to meet their patient outcomes, what they care about in their lives, is important to pay attention to. And we also don't want to have unnecessary patient harm and increased costs. And there's lots of data out there that says that we really have a great opportunity here to improve safety as well as reduce costs. So what I would like to do now is I'd like to turn it over to my colleague and friend, Bryant Campbell, who works as a patient advisor in a volunteer capacity for Providence Medical Group, to kind of talk about how, as a patient advisor, he's worked in partnership with Providence on this whole issue of support for patient and family voice. Bryant?
Thank you, Mary. Good afternoon, everyone. My name is Bryant Campbell, and I am a patient and family advisor for the Providence Medical Group in Portland, Oregon. I've been an advisor for almost 7 years, and I'm excited today to be able to share a little bit of my story and tell how Providence has partnered with patients in order to have some better engagements and utilize some creativity and innovation in how they do business. So Providence has several advisory councils. One is the Executive Advisory Council, and then we have clinic PFACs. Our advisory councils, it's important that they're made up of multi-generational, multi-age, multi-ethnic patients that have the opportunity to be engaged at many different levels in order to bring the voice of the patients into the processes at Providence. And Providence has been really successful in utilizing the patient and family advisory councils in order to bring the perspective of the patients into healthcare. And so as you see from the slide in front of you, we have our executive PFAC, and which is made up of members or patients from both the clinics around the state as well as those that are family members. And this is unique, and it's very useful in that it allows Providence to have a system where we can bring a collective voice to the table of all of their patients in order to cover areas that either address the needs of individual clinics or system-wide, and have a way that information can flow back and forth. Back in 2011 is when Providence began its journey into utilizing advisory councils, and we worked really hard in order to make sure that we designed a system that really had value both to us patients as well as the Providence healthcare operations. So as you see here, we worked hard at the very beginning to establish the roles, to really create some subcommittees that were informational and useful in order to bring information back and forth and to allow for engagement at whatever level. These led to some really unique opportunities for PFAC members to be able to attend conferences and to really present at meetings and to have some full system-wide engagement. Some of the things that happened after that was the opportunity for us advisors to engage with EPIC and with the MyChart, and to be able to help to design materials that were useful for patients and also to help to redesign some information and materials that patients use. One of the great projects that we worked on was an animated media project that allowed us to put an animated video into our clinics in order to describe to patients what actually a medical home looked like and how they could access their medical home team and be able to identify what was the best usage for that. One of the things that was really important is that we defined what it is to be an advisor and how to be an effective advisor. And it was important that we as advisors were on the same page in designing charters and language and identification in order to make for a successful environment. And part of those included listening and learning from the organization's viewpoint and from other advisors, how to overcome fear, how to ask questions, and how to really use our live experience and to give value to the PFAC itself, as well as to other patients. Right here, I'm showing a picture of the clinic that I belong to. And so it's important that after we started up the Executive Advisory Council, Providence moved into the clinic-specific patient and family advisory councils. And this is a little bit different than some organizations have done it, but this is the way that Providence did it. And so after the executive PFAC was developed, we began to move and to design and develop our clinic-specific PFACs. And what's really wonderful and unique about these committees is that they're made up of patients and families that are receiving services at the specific clinics. And during the meeting, the advisors get the opportunity to work on projects that are unique to the clinic's needs and to the needs of the patients. It gives the clinic the opportunity to be involved into the communities that they serve, as well as to engage at a deeper and higher level that will allow for better outcomes, and allows the clinic the opportunity to be meaningfully engaged at levels that typically clinics don't get the opportunity to be engaged at. Some of the opportunities that we've had by the clinic advisory committees is the opportunity to work on projects. And some of the significant projects that we worked on, as you see, was the medical home brochure. Now, this brochure was completely created and designed by patients in partnership with Providence. Patients were used in order to come up with the language that was inside, to make sure that the language was patient-friendly and that it had meaningful content to patients. The picture on the front is an actual patient, myself, as well as clinic staff that was in an actual clinic. This was important to the patient and family advisory councils because we wanted to make sure that all of the information was useful and was meaningful to patients. And so we really took time in order to make sure that everything about this brochure had meaning and that the content was relevant and that it was useful to patients. Another important project was the patient portal. The patient portal, of course, is the patient's way for us to connect to our healthcare providers and in a virtual way and through the internet. And so what we did was we got the opportunity as patients to go through the patient portal and to look at every aspect of that and to help Providence identify areas that we as patients recognized and identified as areas that could be improved. And as you can see on here, it says the medication information was only available from deep links inside the health record. And as we reviewed the patient portal, we identified that when it came to medications information, that was an important thing for patients to be able to have ready access to and to be able to get to quickly. And so we got the opportunity to go through the complete patient portal and to be able to give information, ideas, and guidance on all of the areas that we as patients felt were really important. And as you can see, even at the bottom, we even gave advice on what types of information needed to be prominently displayed on the patient portal. We utilized the entire PFAC community in order to do this, both the executive committee as well as our clinic committees, in order to really make sure that these things had value and that they were going forward. The patient portal is an important part of a patient's healthcare experience. And so we wanted to really showcase and highlight those areas that we as patients knew would be important to other patients. We did some surveying of friends and relatives and really came back and brought Providence some very useful information that once they implemented, they found ended up having a reduction in phone calls and questions about where to find things and how to access the system and other areas that at first they were struggling with how to deal with some of the feedback they were getting from patients. And so as a PFAC, we're really proud of that. Another area that we looked at was working on this project in front of you, which really addressed pain. And so Providence had identified that there was a need to communicate with patients regarding how pain management works and what is it that we as patients could do and how we could do it better in order to better manage the pain that we as patients are in, and even the usage of medication and how to best have outcomes. And what we did was, this was a great opportunity for patients across the system to come together in order to design a flyer that then ended up in Providence clinic locations that really helped to explain in what we figured was patient-friendly language in order to get a message out to the patient community on how pain affects your body and your brain. We started this off with a meeting with our executive PFAC, and during there we had a meeting with Providence staff that came and brought an example of what they had designed and what they thought would be a useful tool to communicate to families and to patients. We got the opportunity from that point in order to put together a subcommittee and to utilize an outside subcommittee of patients and Providence employees in order to then go through the language and go through the visuals in order to come up with the visual that you see there. There were patients that were utilized both from the clinic PFAC as well as the executive PFAC in order to make sure that language was flowing and that we had significant input, not just from one clinic, but from clinics around the state, recognizing that different communities see things differently and have different needs when it comes to visual aids and communication. We brought back all of that information and created this poster that you see in front of you that we really thought was a useful tool that could go into emergency rooms and into clinic locations in order to make sure that there was some effective communication about how pain works. And we really came out with this product, and we're proud. And this product ended up being almost a completely redone product, and it was accepted by Providence and by their marketing team and their executive team as a useful tool to be utilized throughout the Providence system in order to educate and to give a visual aid to patients. One of the things that's important for the Patient Family Advisory Councils at Providence is up in the left-hand corner of that picture, you'll see this little emblem there that says PFAC at the bottom. And one of the things that we designed as Patient Family Advisors is what we call our PFAC seal of approval. All of the items and all of the areas that the PFACs within Providence work on get this advisor seal of approval. To us, this is a symbol that shows the rest of the patient community throughout Providence that this is something that patients had a voice on and that patients had influence and impact on. And so this is just an example of how you can utilize patient family advisory committees both in clinics and in an executive capacity in order to create a product that really is useful to your patients. So I want to thank you for your time. And next you're going to hear from another patient, Randy, and Randy's going to share with you from his perspective and some ideas that he has. Randy?
Well, thanks, Bryant. And let me right past myself there. Let me introduce myself and my particular perspective that I want to bring on medication management and safety based on my own personal experience and my professional experience. So who am I? Well, I'm a survivor of pulmonary embolism. In 2002, I learned I was factor V Leiden. So I am now a lifetime anticoagulant patient. I happen to be on warfarin, and many of you know how tricky that can be to manage, and the opportunity or the requirement really for working between provider and patient very closely, and also very closely with the family of many patients to make sure that compliance is at the right level and time and therapeutic range is maintained. I became a volunteer for the National Blood Clot Alliance for 9 years, and I've been the CEO since August of 2014. So much of my perspective on medication management, safety, and adherence is affected not only by this personal experience, but by the professional experience I have of dealing with literally thousands of people each year who have questions, concerns about their medication for their coagulation problem and how best to manage it and get the patients involved and the family involved. Let me give you a quick history of me and blood clots, because I think it explains a lot. If you'd asked me in November of 2002 what a blood clot was, I would have hesitated and stumbled, totally clueless. But by December 10th, 2002, I was in the emergency room with something that certainly hurt really badly, a heart attack, heartburn. Well, it turned out to be bilateral pulmonary embolism. I'd like to say that that experience were the beginning steps in really learning and understanding blood clot knowledge and wisdom. But I was on morphine, so while it's wonderful for pain, as many of you know, it's not really good for retention of information. And that leads me to my first provider alert, which is any patient who is in pain, on medication, and in the emergency department particularly, is not paying a lick of attention to anything that providers are saying to him or her. So whatever is said needs to be reinforced often. Patients are, as many of you have seen, just not focused, but let me reiterate that they are not focused. In the family, we often talk about patient-family engagement. Well, my family thought I was going to die, so they were terrified and equally useless in gathering information about what was going on, what medications might be required, what the next steps were going to be in terms of my hope for recovery. So even for the family under those circumstances, frequent and vigorous reinforcement of the messages is critical if they're going to walk away from the emergency department with any understanding or appreciation for what's going on. As a general rule, repetition is critical to good medical outcomes and to effective relations between patients and healthcare providers. And sorry there. A little bit more of the personal journey. I get discharged from the hospital. Still pretty clueless. I enjoyed my stay on morphine though. But one area that I want to touch on are the discharge instructions around medication when a patient comes out of the hospital, begins that transition of care from an institution, perhaps going to a different institution, rehab, or going home. In my case, I was going home. The discharge instructions that you see in the slide were literally what I got. Here's a pamphlet, read it. It'll tell you about warfarin. Here's a sponge and a hypodermic needle. You need to practice this until you can inject the needle in yourself to give yourself the Lovenox you need tonight. Oh, and by the way, take this pill before you go to bed. That was the warfarin. And that was it. I didn't even have time to read the pamphlet on warfarin while I was in the hospital. So part from the patient perspective, the discharge instructions really need to be stronger, need to be focused, need to be reinforced. Hopefully a family member would be there to collect that information along with the patient. That, in my case, was not what happened. I was still by myself. My family hadn't come to pick me up. So I got the mini lecture all by myself, and I'm trying to remember, what do I tell my wife when I get home about my medication? Now, as I said, I'm on warfarin, and as you know, there are a lot of new therapeutic options for patients and physicians to choose from. But my experience and the experience of many people that we deal with in my organization is that choice is a challenge. And discharge information that your patients are getting may not be any better than it was when I was discharged. Would like to think it was, but it may not be. So basically your practice isn't going to be able to rely on the emergency department or the hospital to teach the patient or the family or even choose the best drug. They don't know your patient like you do. And you're going to have as you know, a real responsibility for that transition and that ensuing transaction around the medication that the patient is on and its safe and effective management. It's just not happening in the institution, and we're also seeing, as you know, changes in the management of patients with clots in the emergency department as we use the newer direct oral anticoagulants. So when I left the hospital, I didn't know I was factor V Leiden, did not know I would be on anticoagulants for the rest of my life. In fact, I didn't learn any of this until I was out of the hospital about 3 months, and when I had a specialist consultation, I was informed that I was factor V Leiden and informed then what it was meant. Totally changed the treatment plan that I was on. So here's the key point and takeaway for me in that experience for practices. When you start a treatment plan, know your patient. Even an adherent patient, and most of us aren't terribly adherent, as you know, but an adherent patient is not going to be doing well with the wrong therapy. So make sure it's right up front. And inform the patient and the family, but make sure you and your staff are informed as well. Make the time to learn about the patient's needs. Good medical compliance is not going to happen if we're all talking past each other after discharge and when we're back in the care of our primary care physicians or perhaps a specialist for a period of time. There's got to be tremendously effective communication at that point as well. One of the resources that I like to recommend to individuals and also to their healthcare providers is the National Blood Clot Alliance. I'm a bit prejudiced, of course, since I've been a volunteer and an employee there, but we're a nonprofit voluntary health organization that deals entirely on the issues of blood clots, understanding what they are, understanding how to manage them, so forth and so on. We're a lay organization. We have a medical and scientific advisory board that advises us, staff of 7, 3 of us are patients, and we're located just outside of Washington, D.C. Now, this is my organization for my condition, but there are other similar organizations for other conditions like the American Diabetes Association. I think it's important that as you're connecting with your patients over medication management, that you make sure they are connected to these kinds of external resources that can support them, educate them, teach them the right questions to be asking you as a provider when they are in to see you, so that you have an effective dialogue between the patient and the provider at all times. These are the goals of the National Blood Clot Alliance. They're not terribly different from the goals of many other health organizations. We're just focused on the need to educate about blood clots. It's a very large problem, as you know. 1 million people have them every year, and there are about 100,000 deaths. But one of the things that I think is an important goal for us, and I think very relevant to this metric, is our stress on the importance of patient and family adherence to the anticoagulation therapy requirements. It doesn't matter to me whether you're on warfarin, Xarelto, Apixaban, pick your drug. The important thing is that you are adherent, and because the only thing that stands between a patient with a serious clotting disorder and the coffin is adherence to their medication. So that maybe that's the right motivation for everybody. Just some activities that we do at the National Blood Clot Alliance. We work with CDC. We have an initiative on women's health. We are involved in a lot of patient-centered research through the Patient-Centered Outcomes Research Institute. We work with hospitals and medical practices to help them improve their blood clot management outcomes. So there are just a variety of activities that we think support the patient, which is why I make this pitch to you to use this resource when you're dealing with patients who have clotting disorders. As I said again, there are certainly other organizations in that deal with other medical conditions, but this is my particular favorite. There we go. And we use a lot of social media to have outreach and education and interaction between the patients and our organization. We have a very active online support community of 1,500 people and growing, and I highly recommend that to you and your patients who are dealing with blood clot situations. And again, there are comparable organizations for other diseases. These are resources for the practice to help your patients be more compliant and more adherent on their medication, and also I think helps the practice be more adherent as well. Another provider alert: if you're dealing with blood clot patients, there's several special events. DVT Awareness Month in March, National Women's Health Week in May, AFib Awareness Month, October 13th is World Thrombosis Day. You can encourage your patients to participate. You can participate as practices in some of these activities and build the kind of relationship between patient and caregiver around these special events that I think is very important in effective medication management. A couple of things that we need to do in closing. I think we need to do better in prevention around blood clots, and I could probably say that about a lot of other things. A lot of blood clots start in the hospital. We just need to do a better job about that. We have good tools. They don't get used. Constantly, we hear about delayed diagnosis or misdiagnosis. This is a major problem in our arena, and I know it's a problem in others as well. We encourage risk assessments when people are admitted to the hospital so that if they need prophylaxis for clots, they get it. Particularly improve patient family education, especially during care transitions. My own experience with care transition was dismal, and I think this is an area we can all do better. And I think the patient advisory councils that Bryant was talking about before is a very good tool to help understand that better and help integrate into the practice some of the steps that are needed. Patients and families need to understand that anticoagulation are life-saving and life-threatening. As we know, very high risk of being admitted to the emergency department because of a mistake in anticoagulation. And people need to understand that and how to maximize their benefits. And they're going to be looking to you and perhaps to support groups like the National Blood Clot Alliance that develop that understanding, which is going to improve their outcome from these conditions. And again, I think this applies to a lot of other diseases. As I said, anticoagulants save lives, but errors are common. It's very important that practices teach patients and families safe medication use, particularly with the newer oral anticoagulants, since they are new both to practitioners as well as to patients. And make sure for the duration of treatment, whether this is 3 months, 6 months, or the rest of a person's life, that the practice and the patient and the family are working together and not talking past each other. Blood clot survival is a team effort. Diabetes survival is a team effort. This goes without saying across a lot of things. I'm speaking, though, from my own particular experience in that. This is how to find me. If you care to find me, you'll have these slides later, so I don't need to go into that. And I'm going to turn it back over to Mary, who will be wrapping up with some resources that you might find helpful as you implement these interventions. Thank you.
Thank you, Randy, and thank you, Bryant. It's really useful to hear from the patient perspective how what we do in healthcare impacts them both positively and areas and opportunities to improve. So what I want to do right now is go very quickly through a number of resources that can help support your implementation of PFE in these 3 areas. The first has to do with support for patient and family voices. And in a minute, you're going to be seeing it. So one of the things that you can do is look at a getting started guide if you're interested in creating patient and family advisory programs and integrating patients and families into your improvement efforts. And there are a number of approaches that you can take from identifying patient and creating patient and family advisory councils or integration. And we have within this advancing the practice of patient and family-centered care and primary care, in that document there really is a kind of a checklist that lists the pros and cons so that you can think related to what your practice is trying to achieve in engaging patients and families in operations and governance. What model might work best for you? The PCPCC SAN website is just full of wonderful information and resources and tools that can help you create a mechanism and an infrastructure, simple infrastructure on inviting patients and selecting them to participate in improvement activities. And some of those are on the website. We also, for your ease, have put some of them, not all, on in the documents that are part of this webinar so that you can download them. There also are a number of really great videos that kind of tell the story that can be very compelling, and sometimes when you're talking with staff and others and you're getting ready to launch an initiative for support for patient and family voices, it's helpful to hear how other practices have worked with patients and families. Bryant's done a great job of talking both at a large system level, how Providence Medical Group has worked with patient and family advisors, but even at an individual clinic level. And I know some of you are very small practices and some of you are in bigger system kinds of practices, but hearing the different stories can really illuminate what might be possible. In terms of e-tool use and patient portals, if you haven't integrated or implemented EHRs in your practice and it's something that you're interested in considering as an option, there is a great website, a government website that really helps you assess your readiness and how to implement and to really assist practices in having success. Many of you may have patient portals. This is a picture of the patient portal that I use as a patient in my community. And one of the things that's important is it's not just enough to have a portal, but how are you engaging patients and families to increase the use of the portal? And I know that Bryant's group created tent cards that went on waiting rooms. They had patients and families in the waiting room helping enroll patients and families to utilize the portal and to talk about how great it was. But do think about how you're trying to increase the uptake of the use of your portal. I talked a little bit about open notes, and there are tools and resources if you want to go beyond the portal or show more than just the medication list and the problem list, but actually share the notes that were written and are in the electronic medical record that can really help with communication and to reduce misunderstanding and to really embrace patients and families as true partners as members of the healthcare team. Now, some of you may not have an EHR, and I just wanted to let you know that e-tool use is really about what are the electronic tools out there. And so there are other tools out there. There are practices that are using texting to share appointment information and reminders, but they're also using it to say we've got information about X, please contact our office. Or How's Your Health is also an electronic tool that's evidence-based and is out there and available for patients and families to use and for practices to adopt. And I know a number of very small practices with 1 or 2 docs have really found How's Your Health a great alternative to being able to implement a huge EMR because of its cost. So those are some options to consider. In terms of medication management, and I think Randy did a great job of talking about how important engaging with patients and families is so as to create safety and understanding and an informed choice around what medications need to be taken and how to best take them. But there are other organizations that have information and assistance and tools through the TCPI program to assist with medication management. The AMA has their Steps Forward curriculum and has a number of tools and an online module to learn more about it. So that's an area where practices can get support. I know from working with the ACP, which is the American College of Physicians, which is really internal medicine docs, that they have within their practice advisor a module that was developed called Collaborative Medication Management. And it really has a biopsy that you can take to evaluate where you're at in your practice in terms of collaborating with patients and families on their medication management, strategies, tools, and resources. And it's very in line with patient and family-centered care and the strategies for person and family engagement. So there are, those case studies especially can be extremely helpful. And then there are resources out created by public and credible resources. And this is just an example of one that you have that you can download that is a medication management toolkit for patients and families to use, and it was developed in partnership with patients and families. So we wanted you to know that there are those resources out there. Those were specific, and there are more resources than that, but I wanted to let you know that the Institute for Patient and Family-Centered Care has a variety of resources. We also have what's called our PFAC network, which is really a learning community for clinics and patients and family advisors who want to work together and want to learn what other folks are doing and share suggestions, share successes, and also share challenges and get feedback from people who maybe are a little farther along in your journey and in the journey of partnership with patients and families and can give you some advice or share some things that they've done. I talked a bunch about the PCPCC SAN resources, but I don't want you to not be reminded that there are tools for clinicians and practices as well as for patients and families. So please use that resource. There are also a couple of resources that I want you to know that are available that could assist you. One is the PFE Metrics Survey Guide and talks about the definitions and gives more examples of tools and resources. But probably the encyclopedia, which we call the Compendium, of resources aligned with the PFE metrics. It's everything you wanted to know about those 6 metrics, not just the 3 we talked about today, but those others that we talked about last month in a webinar. And they have articles, videos, guidebooks, curriculum, and tools. So really the issue is, where are the resources to help me? Well, they're at your fingertips, and they're there to assist you. However, what I would really encourage you to think about is, what is it that you need in addition to information to be able to move in this direction? Because patient and person and family engagement really is a key strategy in order for you to meet the goals of your TCPI program of improving quality, enhancing the patient and family experience, and reducing costs. So I want to be able to turn this over to Jacinta, because you've been a great audience, and we hope that you've found lots of ideas and suggestions and have a better sense of what the PFE metrics are about and the intention behind them, which really is to create strong and active partnerships with patients and families. But there may be some questions that you have of Randy or Bryant, who have been in the trenches working in partnership with patients, with practices, or from me about the metrics, as I was on that metric performance team developing them. So I want to turn it over to Jacinta so we have some time for questions. Jacinta?
Thank you so much. So we do have a few questions, and so I'll start right away since we have 5 or so minutes left. So our first question is, how do you address high-risk medications with elderly patients, and also including information about what's covered and not covered? So I'm assuming that goes to Randy. Randy, do you want to tell us a little bit more about how you, or your experience, or how you kind of encourage other providers or patients to kind of get more information about their high-risk medications, especially in the elderly population?
For a population like that, and many of them are people who are taking anticoagulation medication for cardiovascular reasons, we strongly urge engaging family members. And if there's not a family member, if the person's somewhat isolated, identifying a caregiver who can assist in this. Now, this may be a home health professional. Very often it would be a neighbor or a friend who can step in and take this role, because that's a very risky period for patients. You know, high-risk drugs, high-risk circumstance being very elderly. So we really encourage bringing a family member or caregiver in to make sure that the patient remains compliant and safe. We think that you know, there are various tools that have been talked about here, and others that practices can use to engage those kinds of people, but it's really critical to have someone who is there at the side of that patient.
Have you ever experienced a situation where the patient, you know, wants to adhere to their medication, but it's not covered, or they don't have much understanding about what is covered and what isn't covered under their insurance plan?
Yes, we get particularly with the introduction of newer drugs, which tend to be on higher tiers and more expensive, we get a lot of calls about insurance, and this can be Medicare, it can be Medicaid, or it can be private insurance. We try to walk people through how their formularies work, because many people really don't understand that well. We also try to identify for them resources at pharmaceutical companies that can help pay for co-payments, or places where they can get reduced price drugs to make up for either poor insurance or just low income. And we also try to help people understand how formularies come together, and encourage them to have a very direct conversation with their clinician, who's their prescriber, about the financial circumstances that face a patient and the family, because that can very often affect the choice of therapy. And if you don't say something, the clinician's not going to know necessarily, and will prescribe something that may not be covered, may be very expensive because of the copay. So we encourage patients to be very frank about the financial impact of some of these drugs, and we try to help them make the right inquiry if they have insurance to learn that information.
Well, thank you so much. That's extremely helpful. It was a question, a detailed question, and you really covered all bases. So thank you so much, Randy. So for Bryant, we have a question more so about how you got started in the advisory council. So there's a few questions, but it kind of sums up your beginning stages. So how did Providence recruit you as a patient advisor, and did they offer you any incentives to participate? In addition to that, did you receive any training before you were a member, and how often do you volunteer? I know that's a lot of questions, but it kind of just sums up your beginning stages and participation with Providence.
Sure. So at the beginning, Providence reached out through our primary care physicians. So I had a medical condition that I had gone through. And long story short is that my doctor, after going through and being diagnosed and the process that it takes to get that diagnosis, my doctor had advised me that there was an opportunity that Providence was creating patient family advisory committees, and asked if I was interested in being involved. Now at that time, it was at the very beginning of forming the councils, and so there wasn't much known about the opportunity. But they did reach out to me through my doctor, and then kind of took me through a general onboarding with the coordinator for the PFAC, and I got an opportunity to go through an onboarding as the new employee would, to learn about Providence, to learn about what the opportunity would look like, and all of the areas that we could engage. And that was kind of the process. I know that's a short answer. I know we're running short on time, but I just wanted to say that there are lots of ways of reaching out, and we now give advice on how to reach out into patient communities and make sure that the councils are diverse and that they have a lot of depth and meaning to it. But there's a lot that happens as far as onboarding. We got training, we got Providence identification so that we could get into the Providence facilities for meetings. And as far as any honorariums or anything, in our committee, we don't have those. Providence does provide us meals during the times that we meet, whether it's lunchtime or whether it's dinner. But at Providence, there's no compensation. All of us advisors are 100% volunteers.
Wonderful. And how often do you volunteer, or how often does your PFAC meet?
PFACs meet monthly, and then there are the subcommittees that meet outside of those, and so there's opportunities to engage at whatever level you have time available, either for the monthly meetings or for joining in with any of the subcommittee meetings that you can volunteer for.
Awesome. Thank you so much for answering that question. It was really, really helpful. Well, thank you all. This concludes. Yes, thank you. This concludes today's webinar, but please feel free to contact us. My name is Jacinta Smith, and we also have Liza Greenberg. She's our program director at the PCPCC SAN. So if you have any additional questions, or if you have any questions for Brian, Randy, or Mary, we'd be happy to pass those along. Again, the webinar and the presentation slides will be available on our website by tomorrow afternoon. And thank you so much for attending our webinar, and I hope you have a great rest of your day.
Thanks, everyone. Bye.